My dear students, up till now, we have finished rheumatic heart disease. We are done with different valvular conditions like mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, and infective endocarditis. Today, we will cover up ischemic heart disease and we will cover this lecture in two portions. First, we will discuss the pathophysiology of the disease and thereafter the different types of ischemic heart disease like angina pectoris, unstable angina, base metal angina, and then we will discuss the management of these conditions. In the second portion, we'll discuss acute coronary syndromes. So, in the first 20 minutes, we'll start with ischemic heart disease as a whole. You know that by definition, ischemic heart disease is condition in which insufficient amount of blood is supplied to the heart muscles. And in most of these conditions, the commonest cause is an atheromatous plaque within the coronary artery. And this plaque is formed as a result of different risk factors like smoking, like alcoholism, dyslipidemia, uncontrolled diabetes, and uncontrolled hypertension. However, there are also uncontrollable risk factors, which I will discuss in the subsequent slides. In the left side of your uh, picture, you can see a vessel opened up with an atheromatous plaque, mostly rich in lipids, but this plaque also contains inflammatory cells and fibrous tissue, muscles. And there are two types of plaques. One is a stable plaque, another is an unstable plaque. What's the significance of stable and unstable plaque? We'll discuss in the subsequent slides. You can see on the right hand side, the picture on the right side, top right, the atheromatous plaque, which is rich in fat. You can see the yellow fat, and then it has a thin fibrous cap and is encroaching upon the lumen of the coronary artery. On the left side, the vessel is absolutely normal. On the bottom side of the picture, you can see the histological picture of the plaque. You can see the endothelial cells, and beneath endothelial there are crystals of fat inflammatory cells. So we can say that this plaque is an plaque which is rich in fat, which is rich in inflammatory cells, and these are the plaques which cause an acute coronary syndrome because once they rupture, the platelet get deposited on the surface of the plaque and followed by thrombus formation. This picture nicely tells you different types of ischemic heart disease. In the middle side, you can see the atheromatous plaque, which is almost encroaching upon the lumen, and these are the patients who suffers angina on demand. You see, they feel pain in the chest on exertion, and once uh, the exertion is over, they feel all right, the pain is gone. And these are the patients who suffer from ischemic heart disease, which is stable, and we call it as stable angina pectoris. The topmost picture you saw, there's a red clot which is filling the lumen of the vessel. In here, the plaque has ruptured, followed by thrombus formation, and it is completely occluding the vessel. This is a case of acute myocardial infarction, unstable plaque. And lower down, you hardly see any plaque, but still the wet vessel is constrict, is gone into spasms, mostly in the cases of prismatic angina. So you have stable angina pectoris, you have unstable angina in which the plaque has a little bit of platelet deposit on its surface, followed by few thrombin fibers and then coronary artery spasm. And then you have acute myocardial infarction in which the artery is filled with red thrombus. On the right side, you can see controllable risk factors. High blood pressure not only causes coronary artery disease, also a risk factor for stroke, heart failure, and kidney disease. And then dyslipidemias, particularly high LDL level, low HDL level, and high triglyceride levels are risk factors for the formation of the plaque, which I have shown in this picture. And you must remember that it targets in patients who are suffering from ischemic heart disease. The LDL level should be below 17 milligram per deciliter, and the triglyceride level are to below 150 milligram per deciliter. Smoking leads to inflammation of the coronary vessels, damage to the endothelium, and plaque formation. And they also predispose coronary artery spasm. Physical inactivity is an also risk factor for coronary disease. Obesity is a risk factor for coronary disease because most of these persons, they have insulin resistance, they have diabetes mellitus, they have uncontrolled hypertension, they have hyperdyslipidemias, and similarly, uncontrolled diabetes is a risk factor for coronary artery disease because it leads to damage to endothelium and plaque formation. Stress and anger can lead to plaque rupture because they lead to increased level of catecholamine in our circulation and can lead to damage to endothelium, and sometimes they can also cause plaque rupture. Again, male sex, a family history of ischemic heart disease in male at the age of 55 years and in females at the age of 65 years is a risk factor for coronary artery disease. And old age is also a risk factor for coronary artery disease because the older you are, more likely you are going to have a plaque in your coronary vessels. The plaque in your coronary artery, if you see that at autopsy in even at the age of 30 years, 40 years, you dissect the vessels, you can see there are small plaques in the coronary artery. So it's an ongoing process. So in most cases, the plaque is asymptomatic. You have a coronary artery disease which is asymptomatic, or the plaque ruptures without any warning and the patient dies suddenly. Then there is a condition we call stable angina in which the patient feels chest pain on walking. There is ischemia on demand, and once the demand is over, the chest pain is normal. And then we have acute coronary syndrome, so-called unstable plaque, in which the plaque rupture with thrombus formation. And there are three conditions on descending: unstable angina, non-ST elevation MI, and ST elevation MI. And then finally, there's a condition in which there's a very small little plaque in the coronary vessel, but still there is predisposition for coronary artery to go into spasm, and this condition is called prismatal angina. So we have stable angina, prismatal angina, and unstable angina. And you can see that on the top left side of the picture, there is a normal coronary artery. Then there is a plaque. Then in the middle, you can see the plaque is almost completely filling the coronary arteries. And these are the cases where we will develop stable angina pectoris. On the bottom left side, the plaque is partially filling the coronary artery. These are the unstable angina or non-ST elevation MI patients. And on the bottom right, the clot has completely occluded the coronary artery. These are the cases of acute myocardial infarction with ST elevation MI. Typical patient of angina pectoris feel pain in the center of the chest, a sense of squeezing, a sense of constriction, as somebody is sitting on the chest, and this pain may or may not radiate to the inner side of the left arm, it may radiate to the right arm, it may radiate up to the jaw, but lower jaw, not the upper jaw, and neck. And sometimes the pain is felt in the epigastrium. These are the typical symptoms, but the patient may have atypical symptoms, particularly in elderly patients, and diabetics. And they do not have any chest pain. They just suffer from breathlessness, dyspepsia, and fatigue, and then sweating, weakness. So these are the atypical symptoms. But in most cases, you find a history of central chest pain behind the sternum and a sense of constriction behind the sternum. And patient, you see the patient putting his hand on the chest and they're just squeezing the hand. These are the features that are typical of angina pectoris. You can see the patient is having pain on the left side behind the sternum, then radiating to the neck, then the pain radiating to the neck and left shoulder, the pain, atypical pain in the epigastrium, and then the pain having behind the sternum in the neck, pain only in the neck, left shoulder and inner side of the arms, and sometimes rarely in the back of the chest, because if the patient has the pain in the back of the chest, usually is a case of dissecting aneurysm of aorta. But rarely in patient with ischemic heart disease, you can have pain in the back of the chest also. So the patients have got stable plaque and they've got at least 70% occlusion of the coronary artery. They feel pain which is brought on by physical exertion, and then it's relieved by rest, and it lasts for 10 minutes or less than 10 minutes, and it is relieved by sublingual nitroglycerin. So in stable angina patient, the pattern of pain, the site of pain, the radiation of the pain is similar throughout the course of disease. It is not changed. Whereas in unstable angina pectoris patient, when there is little erosion of the plaque and deposition of the platelets on the surface, the patient starts feeling pain at chest and the chest at rest or minimum exertion, or the severity or intensity of the pain increases, or there's a radiation to a different site that the patient was not having any radiation. Now you start having feeling pain in the neck or inner side of the left arm or right arm. So this is a new condition, the new radiation site. We'll say the patient is unstable, or if the patient is pain is prolonged, then we will say that the patient is having unstable angina. So this is the definition of unstable angina. New onset on top of a different uh, type of pain, a radiation to a new site, and the duration of the pain is also increased, so more than 20 minutes. Uh, how will you investigate? Usually you order blood examination for lipid level, blood glucose level, blood complete examination to rule out anemia as a precipitating factor for coronary artery disease. And you also order serum cardiomyomarkers, like the different markers of myocardial injury like TROP-T and TROP-I and CKMB. You order resting ECG, you see sometimes, most of the cases, the resting ECG may be normal. You order exercise tolerance test in stable angina pectoris to see if there are changes in ECG during exercise. You order resting or stress echo, and rarely you also perform coronary angiogram to see the nature of disease in stable angina patients. This is how we perform the the resting ECG, and on the left side is normal, and then in in the middle you can see ST depression. So these are the features of subendocardial ischemia. On the right side is ST elevation, which is complete due to complete occlusion of the coronary artery, which is in acute myocardial infarction, which we will discuss in subsequent lectures. These are the ECG changes. This is how you perform stress test in patient with stable angina pectoris, and then you see the ECG changes during exercise. And then you can perform the stress echo in patient with ischemic heart disease, and you can see the changes in the wall motions during stress echo. You see on the left side, the left ventricular cavity is normal. On the right side, the cavity is dilated, and the septum is particularly ischemic and is bulging into the right ventricular cavity. This is how you perform a coronary angiogram. You just pass a catheter through the femoral artery or the brachial artery or radial artery into the circulation, and then go to the coronaries, inject dye, and then see the coronary arteries. After that, you pass a balloon. On balloon, there's a stent mounted. You inflate the balloon, and in the bottom side, you see the picture. You see this, there is a stent in place. So you just break the fat in the plaque with dilating the balloon, and then the stent is implanted, and then this stent is covered with endothelium. It's become part of coronary artery. You see on the left side the artery is completely occluded, and then on the right side there is stent implanted, and there is circulation going right down to the right coronary vessels. Once you discharge your patient of stable angina pectoris, you put him on aspirin. If you have implanted the stent, then your patient has to be on clopidogrel for at least 6 months. Beta blocker must be a part of your prescription unless there are some contraindications, and you write calcium antagonist in prescription, particularly if there's an element of coronary artery spasm. You also order sublingual nitrates in case your patient feel angina pectoris. And heparin is to be used only when your patient is having repeated episodes of chest pain, so that you want to halt the progressive thrombus formation, and then you uh, give intravenous heparin or subcutaneous heparin, low molecular weight heparin. And almost each and every patient of ischemic heart disease should be on statins like rosuvastatin or atorvastatin. This is your prescription when you discharge the patient of ischemic heart disease. Then, of course, you advise your patient change in lifestyles, low fat diets, and then he should also lower his body weight, and he must stop smoking. Now, this is the end of the first presentation, and now in the next presentation, I will discuss with you the acute coronary syndrome, in which is plaque rupture and